Hi everyone, my name is Joe Smith and I am the statewide internal medicine sub-internship director. First off, let me tell you thank you. It's our outstanding educators, dedicated faculty, and hosting hospitals around the state that allow IU School of Medicine to create outstanding future physicians. The objectives of this talk briefly are to show you what a sub-internship should be capable of on day one, where we want them to be at the end of the rotation, and how to ensure they get there. So to begin with, let's talk about what a sub-I should look like on day one. In order to understand that, we have to start by saying that by the time they passed their third-year medicine clerkship, they were at the reporter level. In order to pass the third-year clerkship, they have to be a consistent reporter, which means that they can effectively communicate with patients and their families, accurately collect clinical data, organize that data, and present the data in written and oral formats. When they come to you as a fourth-year sub-I on day one, they should at least be able to achieve at the reporter level. You can expect lack of proficiency in things like formulating a prioritized differential, comprehensive and accurate diagnostic workups, and therapeutic and management plans. Giving bad news, they may not be perfect at yet. Procedures, some will have done more than others. Comprehensive discharge planning and discharge summaries will need to be assisted by the staff. And sign-outs and transitions of care will need to be guided by the staff as well. Our goals for sub-Is by the end of the rotation is that they achieve the interpreter level on the RHIME framework, which means that now they've gone past the reporter level and now they're consistently analyzing and integrating data to develop and defend a differential diagnosis. In other words, they have good clinical reasoning skills. They possess clinical judgment to prioritize patient problems. They're able to identify sick versus not sick in a beginning fashion. We also see nascent managers, meaning early managers, students that are capable of providing clinical judgment to develop a diagnostic and therapeutic management plan to coordinate patient care. They may not be able to do this consistently and fully accurately, but they're beginning to try it. We rarely see a consistent manager, and even more rarely would we see a consistent educator in the medical school time. If you look at this chart, you can see the progression over time, noting that in the fourth year of medical school, we see that the fourth-year student should be proficient, P, in the interpreter level, beginning to do things in the management level, and we're asking them to do things at the educator level, but they have not achieved this yet. So how do we get our students to meet these goals by the end of the rotation? Well, we insist on a rigorous rotation that requires structure. So that structure is going to be reviewed now. We want students to write their own notes, their H&P, daily notes, transfer notes, and discharge summaries, and we want them to do that in the chart. We tell the students that they should admit a maximum of 3 new patients per day or per call night and carry a maximum of 6 patients at a time. We instruct them to push themselves but know when to get help. That means a student may start out by only being able to handle 1 new admission and 2 patients on any day. But by the end of the rotation, they should improve. Other students will be able to handle more up front. If you're in an ICU setting, these numbers may be lower. Students are expected to complete a minimum of 5 to 6 calls per month. As the structure of our medical system changes, true overnight call happens less often. Some students will take a short call until 9 p.m. or 7 p.m. on a swing shift, and that can be considered a call. Other students may be in systems where there is no short or overnight call. In those cases, we want to make sure that the students are getting 2 to 3 daily admissions in order to make up for the lack of a bolus of admissions on call. As far as rules for call, the medical school upholds the same rules for an intern and residency. So if they're taking overnight call, they can work a maximum of 24 uninterrupted hours plus 4 hours that can be related to patient safety, such as transitions of care, or require didactic sessions. If they're taking call until 9 p.m., they just have to make sure and have 8 hours between leaving and returning the next morning. There can be no more than 80 hours per week when averaged over a 4-week period, and there needs to be at least 1 day off and 7 averaged. Our students should be working throughout the rotation. They should be working approximately 28 days of total rotation time. They do get 1 day off per week along with their resident. That comes out of that 28 days. If there is no resident, the best thing to do is to arrange their days off to be associated with their staff days off. The students are not allowed to take days off for interviews or other absences unless they're approved by the course director. So here are some tips for making your sub-I an acting intern. We want to make sure the nurses page them for questions on the sub-I's patients. Sometimes that involves implementing team pagers, making sure the operators have the student's pager number, or leaving paper tags on the charts of the patients the sub-I is following so that the nurses call that sub-I. You should make sure that the student writes their own discharge summaries. You may need to dictate them depending on what system you're in, but the student should still have the opportunity to write them and have them reviewed by you. Make sure your sub-I writes their own admission and daily orders. There are different structures for this that work with your flow at your facility. Maybe you have to log into the system and have the student write admission orders within your account and then you sign them at the end after review. Or maybe your system makes it easy enough for the sub-I to write their own orders and for you to sign off on them thereafter. Other tips include making sure that the sub-Is follow and have continuity with the patients they admit, that new admissions should occur routinely, and to make sure that the sub-I is allowed to evaluate a patient independently and offer their assessment and plan to you without the staff being involved before the student gets involved. Unless, of course, there's a critical issue and you need to be involved sooner. They also need to be involved in changeover. Changeover is essential to adequate training when our students will be changing over and signing out patients on a very frequent basis in their residency. If you cannot arrange for a verbal in-person exchange, have the sub-I change over to their own staff for physician training purposes. These are some typical flows for new admissions and for daily care that you can go through on your own to get an idea of what might work at your facility. Here's a similar flow for discharge planning and care. Evaluations for you will be received by email. We need your timely and thoughtful evaluations in order to assign a grade and help these students along. Telling us that the student will be a great doctor, has a great smile, or is a great person does not help us assess how the student is achieving. Rather, we need more descriptive and narrative descriptions of how they're doing, such as MS Smith was able to accurately form a differential diagnosis, prioritize problems, and was beginning to offer logical management plans. You'll now have site leaders at each of your campus centers. There may be a site leader at a different hospital system, but there is a site leader in the area for the sub-I. These site leaders will ensure that regional center rotations maintain the described structure. They'll assist with response to student feedback. They'll assist us in obtaining descriptive evaluations. that avoid grade inflation and are completed in a timely manner. And they'll communicate feedback and ideas to us.